So this section is about choosing an outcome measure and why we might want to use it clinically. So outcome measures are tools that we use to assess a person's change. And so they're sometimes called assessment tools. Sometimes they're physical measurements, if you see here on the right, or they're paper and pencil tests here on the left. The definition of an outcome is a characteristic or construct that is expected to change owing to the provision of a rehabilitation component. So you can break what you do clinically down into a strategy, intervention, or program, just to help you kind of think about how you might want to assess these different components. So a strategy is like a very specific thing like stretching or strengthening that you're assessing at a high frequency, like almost every visit. Or an intervention is like a global strategy. So you're going to do weight bearing, gait training in stroke patients, or proprioceptive training that might have several different strategies mixed in to kind of help that. So you might assess that at less frequently than you would a strategy. And then finally, you have a program assessment where your kind of rehabilitation program for ankle fractures or for ACL rehab, you assess the entire program that you have put together. So there's different reasons to implement an outcome measure and different frequencies associated with those different reasons, and then different selection of scales based on that. So strategies tend to be things that are theoretically connected to why we're doing the treatments. Interventions tend to be a little bit more complex and oftentimes are pencil and paper tests or outcome measures, or a battery of tests that might determine when somebody might go back to play or something like that. And a program assessment is more complex and broader, so it involves things like cost and a number of visits and things like that. So a good model to think about when choosing, what kind of level of outcome measure you can use the ICF model, which is very handy because we think that if we change body structure and function variables and we choose those as our outcomes and our therapies are changing those, then we expect them to have some influence on activities and participation. But if we're not testing that clinically, we might be deceived by different things our patients tell us or positive interactions we have, like the patient's very satisfied, they like us, things like that. But objectively, if we're not assessing whether those changes that we're seeing in the body structure function actually translate to improvements in activities that we might assess, like say with a patient-reported outcome measure or some assessment of return to societal participation, we may be deceived. So ultimately, it's important to define outcomes and understand what level of the ICF model you're assessing, and then also how frequently you might use those.